Thanks very much for joining us. Thank you and welcome. Thank you in particular to Senate staff who have made the trek across the street. We really appreciate your time and attendance to join us here today. I'm John Fawcett. I'm the Legislative Director of Results. We're a grassroots organization working to build the political will to end the worst aspects of hunger and poverty. And we're also a member of the Action Project, which is an international partnership of advocates dedicated to mobilizing resources to treat and prevent the spread of tuberculosis, which is what we're here to talk about today. We're a sponsor of today's event along with our friends at the American Thoracic Society, ARIS, the Stop TB Partnership, and the Treatment Action Group. For World TB Day this week, the title of this briefing is Tuberculosis, We Can Beat This Global Killer. And I like that title because it's straightforward and direct and unambiguous, and it's a straightforward statement about a disease where it's often difficult to make straightforward, unambiguous statements. And what I mean by that is so many of the facts that we know and say and have about tuberculosis come with so many caveats and qualifications that they almost overwhelm the rule itself. So, for example, tuberculosis is curable. And yet we have the continued emergence of drug resistance and forms of the disease that are not only more difficult to treat, but also more costly to treat because of that drug resistance. And the potential emergence of forms of the disease that may be resistant to all of the drugs that we have available, and may in fact not be curable. We know how to detect and diagnose tuberculosis, but the technology that we use to do that in most parts of the world is very old and is very unreliable. It misses too many cases. It takes too long. We have a vaccine to prevent tuberculosis, but it doesn't actually work very well. The effectiveness wears off. It doesn't protect against all forms of the disease. TB is a disease that's often thought of as a disease of adults, not a childhood illness. But in fact, as we'll learn today, it has an underreported and in many ways unidentified effect on children. And there hasn't been the kind of concerted effort around childhood TB that we've needed. And one that you'll hear a lot is that tuberculosis is an ancient disease, and that's true. It's been found in Egyptian mummies, but it is a disease that is still very much with us today, and has collided with modern epidemics like HIV/AIDS in ways that no one could have predicted, or perhaps we should have predicted but did not, with devastating consequences. And so we have a particularly distinguished and accomplished panel today to help us try to perhaps clear up some of this ambiguity, to try to do away with the qualifications and the caveats and the exceptions, and to say definitively that this is a disease that we can defeat. Before we get to our panelists, I want to take just a quick moment to note the passing of one of the real champions in Congress for tuberculosis, Representative Donald Payne of New Jersey. Representative Payne, as many of you know, lost his battle with cancer just a couple of weeks ago. And Representative Payne understood the toll of TB on communities and countries and families, particularly in sub-Saharan Africa, where he traveled extensively, understood the ways in which tuberculosis was, again, collaborating, conspiring with HIV/AIDS to really hollow out communities. And he did more than understand it, he acted on it. And if you look at the history of tuberculosis funding, you'll see a big spike between 2007 and 2008, where US funding for TB for the program that Ariel will talk about in a moment really took a sharp jump. And the story that most people know is that there was an attorney from Atlanta who, against the advice of his physicians, if not common sense, had a drug-resistant form of tuberculosis and went on a series of sort of international flights. And this caught the attention of members of Congress and grabbed some headlines, and you see that corresponding spike in funding. But the story behind the scenes was that it was really Representative Donald Payne who recognized that this was a teaching moment when a lot of people were talking and thinking about the threat of tuberculosis, and insisted on an amendment to the foreign aid bill to increase funding for tuberculosis. And we still see the higher levels that we're at today compared to 2007 are really a direct result of his efforts. So we're going to miss his leadership, and it's in the spirit of that leadership that we're here today. So without further ado, let me turn to the first of our panelists, Dr. Ariel Mendez. Excuse me. He is the Assistant Administrator for Global Health at the U.S. Agency for International Development, a position he assumed in August of 2011. He was nominated by President Obama in March, and he joined USAID's leadership team with a vision to shape the Bureau for Global Health efforts to accomplish scalable, sustainable, and measurable impact on the lives of people in developing countries as envisioned in the Global Health Initiative. He's an experienced public health physician who most recently served as managing director at the Rockefeller Foundation, where he led the foundation's global health strategy on the transformation of health systems in Africa and Asia, and many other efforts at Rockefeller. He's a board-certified internist until recently was practicing as a professor of clinical medicine and epidemiology at Columbia University. And although not in his official biography, he is a renowned expert on TB specifically, and conducted important research into the emergence of MDR TB in New York City in the 1990s, among many other contributions to the field. So please join me in welcoming Dr. Ariel Collins.
Thank you very much, and thanks for joining us today. It's great to see actually many friends. Lushika was saying that it's good to have a friend of tuberculosis, and I say, well, more than a friend, I'm a tuberculosis guy. And indeed, whether fighting TB, HIV in New York, when MDR-TB was truly a devastating epidemic in New York, with Tom Frieden at the time, I had the opportunity to lead the first global report of MDR-TB for the World Health Organization in 1997. In the year 2000, I was also quite fascinated by the moment of tuberculosis and HIV in the year 2000, and we were directly involved in the establishment of the Global Alliance for TB Drug Development, as well as with WHO and many others on the Global TB Drug Facility, and was in the Bellagio in February 2001 Bellagio conference that saw the Stop TB Partnership's birth. So clearly I've been quite involved with the field, and I've seen a lot of progress in the last decade, and I would like to convey some of that to our colleagues on the Hill, and also so I will probably restate some of the basics of tuberculosis in that sense, and then convey to you the work that we are doing in the US government and USAID in particular. Is this on? Thank you very much. And the number of patients with new cases of tuberculosis have been more or less steady as the world has been growing. The incidence is slowly declining, but the numbers have been around there, 8-9 million cases in the world. The number of deaths is been declining. It's approximately 1,450,000 deaths, close to the number of deaths caused by HIV itself, and it's of course the number one cause of death among people with HIV. The geographical distribution, TB in general, is highly concentrated in Asia. But when we look at HIV-TB, it is indeed predominantly in Africa, where HIV, of course, is more prominent. And MDR-TB, we've known for a decade or so, it's been particularly a problem in Europe, Eastern Central Europe, but now we know, of course, it's in every continent as well. As I pointed out, the incidence, that is the number of new cases of tuberculosis, has begun to decline. And it takes a while, as we know, because of the pool of people already latently infected, which is very large. And so that even if you are having very good results on mortality, as we see on this part of the slide, incidence takes a bit longer. But it's now coming down. Mortality itself is one of the MDGs that will be met, decreasing half of TB mortality by 2015 from 1990. We are on track, and I guess the issue nonetheless is that even though the aggregate is so, there are several countries, particularly in Africa, where that may not be so. So we need to continue to work very hard in that space. In this period of time, more than 7 million lives have been saved because of treatment, and just in the last 5 years, 1 million among HIV-infected people. We often think of tuberculosis, we don't sort of frame it in the context of women and children, which is the top priority for our work in USAID, but tuberculosis is indeed quite important since it kills more women than maternity and delivery. And the numbers are very clear in this regard, as well, of course, children. 10% of the cases of tuberculosis occur among children, and more importantly, there are even a larger number of kids that are orphans because of tuberculosis than from many of the other diseases that we look at in global health. The economic impact of tuberculosis has been well studied for a long time, and we know, of course, that it affects the most productive part of life in the adult population. We also know that it's very cost-effective to actually treat tuberculosis, save lives, and prevent the orphan and keep the jobs of those people going. But also, it's been, and I was personally involved in a study that shows that if we invest in tuberculosis abroad, we actually save money here in the United States in terms of the cases among immigrants, secondary cases, and it's a lot more expensive to treat tuberculosis here than to do it with basic drugs around the world. The Global Health Initiative, President Obama's framing of the work that we do in global health in tuberculosis is aligned with the global targets of WHO and the Stop TB Partnership. For impact, it's aligned with the MDGs, 50% reduction in mortality and the burden of disease by 2015. The outcomes that we seek, again, those already established by the community. It's a good thing that we have that clarity in the community of detecting at least 70% of the cases, and we may need to do even more now because we believe that there's room to do better, and treating at least 85% of all TB cases. For the US government and the GHI, we are seeking to treat successfully at least 2.6 million new TB cases, and that's sort of the work that we are supporting, particularly in the priority countries in Africa and Asia, in which we concentrate our work. Partnerships is really the way in which we work. We work in partnerships not only here in the various branches of government, but also with the various other agencies involved. USAID leads the interagency group for international TB control, with great engagement, of course, with the other agencies, CDC and technical assistance, NIH and research, and so on. Partnerships, whether at a community level, partnerships with countries, partnerships in the global level, like the Stop TB Partnership, are also very important. Fostering the partnership between countries themselves has been also very, very key for our work. The type of work that the US government has been engaged involves several things. Again, at the global level, this list of many of the partnerships we have, the most important being the Stop TB Partnership as really the community representation of the efforts around the world against tuberculosis. At country level, there are several examples in this regard. In the interagency, particularly the TB International Working Group, which our colleagues in the want to recognize, Sherry, Amy, and many others that are part of our teams from USAID. So partnership is the way to go forward. Within countries, of course, is also very important, and communities are essential. I like to say, last week I was in Mozambique and Ethiopia, and I could see there are many programs, of course, working with governments and communities. And in Mozambique, I went to Beira to see the community-based DOS volunteer program. And they do great work. At the same time, you almost feel like you wish they were doing many other things, because there are great resources on the ground. And indeed, in Ethiopia, the government of Ethiopia has been advancing the extension health worker model, which indeed does all of that together. And so there's an opportunity for community engagement in the cost-effective ways in which the Global Health Initiative asks us to operate, to do more of that on the ground. And again, many work in countries, particularly those countries that have high incidence and high burden of tuberculosis, as those illustrated in this slide. MDR-TB has been, of course, one of the challenges that got the attention of the national and international community, and it's been a growing problem. And in a way, it is so because we have been successful in extending DOTS. I mean, it used to be that a third of people will die, and they just never saw treatment. Now we are treating patients. Now mortality is coming down. But a byproduct of using antibiotics is that you will see the emergence of drug resistance. And doing it well, of course, with good DOTS programs and with appropriate infectious control is a way to preempt this problem. And the priority for us in fighting MDR-TB. At the same time, once you have MDR-TB, we need to do something about it. And indeed, the work that we all are involved with in improving the diagnosis capacity and often requires technologies that are not simple technologies, but systems like the expert systems for MDR-TB which I've seen deployed in many countries, are helping back-out countries, particularly the national laboratories and some of the regional laboratories, reference laboratories is very important. But the numbers are still growing, and we need to do a lot better in this regard, because otherwise it's leading us, we have heard, to XDR-TB and now total tuberculosis in some places. A concern clearly is the national progression of antibiotic resistance. Fortunately also, the community has been wise, investing also in new technologies. And the working group on new TB drugs and the Global Alliance for TB Drug Development, with many other partners around the world, have been now replenishing the pipeline. That we had 50 years with no new drugs. We were using the drugs we had just after World War II. But now we have a pipeline that is moving, and is moving really in a comparative fashion to those of pharma, so that these public-private partnerships that we set up a decade ago are indeed doing quite well, and it takes a decade or 15 years, 10 to 15 years to deliver. So we are close to that. And it's quite exciting now to see some of the regimes coming, combination therapies that might shorten the treatment of MDR-TB from a total of 24 months down to 4 months. And so that will help a lot in alleviating the plight of patients with MDR-TB, and also by virtue of curing MDR-TB, preventing the spread of MDR-TB strains in the communities where they have been emerging. So I think that that's a sign of optimism for all of us. Last, I would like to say one thing. The world is changing. While our economies have been a bit stagnant in the OECD countries, actually for many low and middle income countries, there's been a growth of 6–8% in many of the countries we work in. And that's a new opportunity for the international community, the advocacy community, to engage domestic resources. Increasingly, in many countries, the resources that do not exist will begin to become available. How those resources are used and whether they are deployed to priorities like tuberculosis is something that depends on the work of many of you. And I'm glad to see a group of African leaders here who are trained on advocacy to explain the importance of tuberculosis, what needs to be done, so that governments indeed can also commit their own resources locally. And I would like to say that that is going to be a way of the future. I mean, OECDs will remain committed. We, in the US government, we have been indeed lucky to have bipartisan support on the Hill for the work that we do in tuberculosis and in global health in general. And so that our budgets on the whole have been holding from our 2011, and Congress was supported in 2012, but we are going with the same for 2013. And we hope that for 2014 we of course continue to do as well. But in the future also, we need to plan to engage the growing resources in the partner countries to do better for their own people. Thank you very much.
All right, thanks very much. And we will have an opportunity for questions for all of the panelists when all have had a chance to speak. Also, if there are a couple of seats up here for those of you that are not shy and want to sit down. Ariel mentioned that there are a number of distinguished guests here visiting us to undergo various training related to advocacy and community mobilization, and we're very privileged to hear from one of those activists next, and that's Carol Narinda. Carol is an international health activist from Lusaka, Zambia, working around HIV, tuberculosis, and malaria. She's the executive director for the Community Initiative for Tuberculosis, HIV, AIDS, and Malaria, CITEM Plus. She's a founding member of the Coalition of Zambian Women Living, where she serves as interim chair, and has set up ACT UP Lusaka, where she leads on international relations and TB/HIV. Internationally, she's held or still holds positions on several important global health boards and committees, including the Global Fund, UNITAID, and the Stop TB Partnership. Carol she's a cancer survivor, she's a TB survivor. She has lived with HIV for many years, and she has transformed her personal experience into powerful national and international advocacy. And we're very proud and privileged to call her a friend and partner. Carol.
Thank you. I'm always glad to be in DC, to speak to, speaking at the Hill, where there are people who can actually, or who I owe my life to. I was given a second chance to life as a person living with HIV, so I'm always happy to be here. So I thought I would start by sharing my experience. I think as you heard, my name is Karen Awinanirenda. I'm a TB/HIV activist. And I think drive my passion. A lot of people will ask me, why is it that you have this passion around your work and you're always open about your status? I'm open even in my country. It was very hard initially for my children, but I told them how important it was for me to be open about my status. But this came about when I found out that I had TB. Actually, I found out that I had TB before I even knew my HIV status. And during that time, I think there was very little information around extrapulmonary TB. So I'm one of those persons that it took over 6 months for my TB to be diagnosed. I went to several health institutions. I had to undergo more than 5 different x-rays for them to diagnose my TB. I was told what I had was chronic bronchitis. They could not detect what it is because as we all know, the tools that we have, especially in our countries, are very old and very archaic. So because of the problems that I went through, when I finally found out my status, I was one of the lucky people who managed to get treatment. In my country where I come from, Zambia, TB treatment is free. So I managed to get treatment and I got cured. And it's from this experience that I thought I should work around community work, and then formed up the Community Initiative for TB, HIV and Malaria. This is a patient-led organization set up by people living with HIV. 90% of us have undergone TB treatment. So even as we work with the community, we do a lot of advocacy at both national and community level. Most of the time we find that people in the community are voiceless. So unless they understand the policies that are supposed to protect them, they will not be able to advocate. So at CITAM, what we do is we translate these policies into a language that our communities will understand. So we create demand on the ground, and then also engage with the policymakers, the NTPs, the Ministry of Health, to try and help them fill in the gaps and change the tools to a kind of level that will work in the community. So I started my work as straight from what we call a support group. This is a support group of people living with HIV and AIDS. So I just want to share with you where I am now. And the reason why I put up these pictures is to show the kind of support that the US government sort of gives to people like me. The money that built my capacity for me to be able to speak at meetings, I'm sure, but I don't know, the bottom picture is not very clear. I was at the UN with Michelle Sidibe, Michelle Kazakskin, and Ban Ki-moon, and I can't remember, but it was the president of one African country. So my capacity actually was built by one of our partners here, Results, and then, like you heard, I'm here having my capacity built around ACSM by PAF. That's funded by, again, the USG. And then the other picture was during the commemoration of the 10th anniversary of the Global Fund. This is the man in red is our new Minister of Health. And then the DG, the Director General of the National AIDS Council. So my capacity was built from just being from the grassroots by monies that come through the Global Fund. Most of our programs for community work in Zambia are funded through the Global Fund. So I want to speak a bit of the role of the communities, the affected constituencies. Once upon a time, once you found out your status, all you did was go back home and wait to die, especially when you have TB. I mean, when you have HIV. I started my activism around HIV before I also realized that TB was the main killer of people living with HIV and AIDS. But once I found out that that was the case, we as affected constituents as well took up the role of also supporting the governments. As you know, most of our governments are overwhelmed. There are so many people, very few health workers. So as affected communities, we've taken up the role to complement the government. We do a lot of treatment literacy in the communities. It's important for them to know about the medication that they're taking. We also, like from CITAM, we train treatment supporters. These are people who go out into the community. They do defaulter tracing. They make sure people take their medication. They're dot supporters, as well as advocacy. We also have adherence supporters. It's important to have adherence supporters on the ground because you might put in so much money into a country, into an organization, but if people don't take their medication well, then you end up developing drug resistance, which, as you rightly said, is actually more expensive than first-line TB. Then we also form support groups. We also support home-based care. People who are really sick who are at home and can't sort of get to the hospital. So again, I wanted to say, for some of the capacity building, especially at the international level, we work with our partners. I'm here talking about partnership. I think I did mention Results. I mentioned Treatment Action Group as well as the PAF. These are some of the partners that are really working with us on the ground at grassroots in Africa. So, like I said, I was co-infected TB and HIV. So most of our African countries, like I said, we have a good tool out there. The WHO policy on TB/HIV collaborative activity is a good tool. Everything is stipulated. It has good data in there, and our countries, like the country that I come from, Zambia, is one of the countries that signed up to this policy. But up to now, I really don't understand why we cannot get the TB/HIV to work together on the ground. It's something that I hope we can get it to work. It's important to also enforce the 3 I's, that's Arizona, that preventive therapy, infection control, and intensified case finding. This is one thing that will help us quickly detect people who have TB in their homes. But for people living with HIV and AIDS, Arizona, that preventive therapy is a tool that can help us. If, for example, I have TB and it's latent TB, then if I get my IPT, that will help me not to have active TB. In Zambia, one of the advocacy issues which we are pushing forward as CITAM right now is to get our government to offer us the IPT. They're refusing to give us IPT because they're saying they're protecting us because we might have Arizona's resistance later. What we are demanding for now is for them to give us an opt-out. So I should be able to opt out whether I want to have the IPT or not, but we are demanding for the government to give us this service. And then it is also important to initiate ART. In some cases, it's still difficult for the TB section to test for TB or vice versa. But if we have the integrated services, it will be easy for people to catch the HIV like in the TB section and initiate ART. So what are some of our challenges? I think we heard that TB is the main killer of people living with HIV and AIDS. But what makes it worse? For some of us, like in my case, for me to access my ART, I have to go to the clinic all the time. These are clinics that are congested, with a lot of people who are coughing. Most of the time there are no windows. But I have to go to the clinic every 3 months to have my vitals checked. And then I have to go and access my drugs, so that I take my drugs for the rest of my life. So in the process of my trying to preserve my life as a person living with HIV and AIDS, I end up contracting TB, which could actually kill me within a few months. I've been on treatment for close to 10 years, but I could go to a clinic, get TB and die within a few months, meaning that all this investment that has been put in me through the HIV program could actually be lost to TB. Again, another statistic is that people living with HIV have increased risk of developing active TB 10% per year, while people who are HIV negative, for them it's 10% in a lifetime. So we have all these challenges. And then there's also the issue of drug stockouts in our countries. Most of the time, the patient is the one who's blamed. They drug resistance was formed because patients don't take their medication. There are times when I want to take my medication, but I go to the clinic and I'm told there's no medication. That happened in my country recently, where people came to the clinic and there were no drugs. So they'll tell you, come next week. For me as an activist, I would cause so much hell, we would find the treatment. But so you can imagine for our colleagues who can sort of speak for themselves. So again, we have few healthcare workers, like I mentioned, so they don't have time to really explain to people about adhering to the treatment or the inadequate infrastructure. What does this cause? Drug resistance, which is more expensive. So there's urgent need, like I said, for effective integrated TB collaborative activities, especially at country level. So our African government increase domestic funding. As activists, that's one of the areas where we are talking, we are pushing for our governments to increase domestic funding. When they met in Abuja, they agreed on the Abuja declaration that African countries should put in 15%. But there are very few countries. I think the last that I heard, I think there are only 2 African countries that had made the Abuja declaration. But then we have some success stories. For example, in South Africa, I went to a meeting, I think about 2 weeks ago, where South Africa is looking at screening all the minors. There's an issue of TB in the mines. So the SADC region has come together, the regional grouping, where they're looking at screening all the minors. So I think this is a positive approach. In most cases we had, like for TB, most of the countries, it's government funded at local level. But then it's very difficult to scale up or sustain the drugs and programs. So this is where I would ask again the USG government to continue funding Global Fund and PEPFAR. I'm here because of Global Fund. I'm here actually because of PEPFAR. The drugs I take are funded by PEPFAR. The programs that I do on the ground are funded by Global Fund. So if the funding stops going to these global health initiatives or funding mechanisms, then it's more like, for me, it's taking my life away from me. And then it's important to empower the community so that we can support the government to do the work on the ground. So international agencies, like I said, they should increase support, especially through the Global Fund, the largest external funder for TB. All the activities in my country that we do around TB, even as volunteers or community-based organizations, are funded by Global Fund. And there's a worry. For example, in Zambia at the moment, we have most of the hospices that are taking care of terminally ill people, or HIV and TB, most of them are closing down. We had a bit of issues with the Global Fund, and some of the money has stopped trickling in, and it's really chaotic right now. I'm really worried because like, my country is one of the countries I think that is going to have a lot of drug-resistant TB because of the problem, because the funding is not flowing okay. So that is the importance of having the funding flow. So as I finish off, I just want to say that patients, we former patients, we no longer want to be mere recipients of care. Like I said initially, we just start and got medication and services, but would like to play a role, actually we are playing a role in the management of our disease to supplement government efforts. The community, as a community, we are playing our part. So now that I'm here speaking to this grouping here, now donor governments must step up to play theirs and making funding the Global Fund a priority. Many countries, as we know, have not put in the money they place to put in the Global Fund. For some people, it's statistics, it's figures. For people like me, when the Global Fund is not funded, it's a matter of life and death. For the constituencies that I represent, for us it's worrying because I don't know whether I'm going to have treatment next week, I don't know whether I'm going to have treatment next year. For my ART, I'm supposed to take it for life. What if I have TB and I know drugs, what's going to happen to me? I have children, what would happen? For some of us, it's not just figures, it's really a matter of life and death. So because of all these problems that we encounter in our countries, like we heard, there's a group of us who have meeting at PATH for a training. We've been talking about coming up with a coalition of African TB organizations. We actually finally formed one. And yesterday, actually, we gave a declaration to the Executive Director of the Stop TB Partnership. So that's a picture with Luchika there, with the declaration speaking to the group. That is the team, the initial team of the Africa Coalition on TB Act, with an exclamation, because we really want to act. So in conclusion, donors must increase support, especially, like I said again, I want to say this several times so that people don't forget, so that HIV investments are not lost because of TB. TB integration is a low-hanging fruit. It's just right out there for us to take and pick. Let us take advantage of it and save lives. Thank you.
Carol, thanks so much. We've heard from both of our speakers about some of the challenges that we have with the tools that we have to fight TB. And by tools, we're talking about the vaccines to prevent TB, the diagnostic tests to detect it, and the drugs to actually treat it. And there are some critical limitations with all of the existing or commonly used tools that we currently have. And our next speaker is going to talk about some of the efforts underway to really address that. Jennifer Woolley is the Director of Advocacy at the ARIS Global TB Vaccine Foundation, a nonprofit product development partnership with the mission to develop new TB vaccines and ensure their availability for all who need them. She's also responsible for ARIS's advocacy efforts globally, including engaging governments, civil society, and communities both in donor countries as well as the endemic countries where TB affects populations the most. Prior to joining ARIS, she has an interesting background. She was the Sexual Assault Advocacy Coordinator for the Virginia Sexual and Domestic Violence Action Alliance, where she coordinated statewide public policy initiatives. And in previous work at the Center for Policy Alternatives, she provided resources and technical assistance for women state legislators and grassroots leaders. So please welcome Jennifer to talk about new tools.
Good afternoon. Thank you, everyone, for taking time out of what I'm sure are very busy schedules to be here today. And thanks to the organizers for giving us a chance to talk today about investing in long-term solutions for TB through R&D for new tools. I want to start with this statement from the recent WHO Global Tuberculosis report because I think it emphasizes what we really need here. It talks about the major progress that has already been made in TB control through the DOT strategy, and progress has been made, and there's tremendous work happening in the field. However, it also talks about the need for new tools, for a transformation in TB prevention, diagnosis, and treatment. that in order to meet the elimination targets that we have and the global targets we have, we do need to look at both and support current implementation programs, but also the research and development of new tools. And why do we need new tools? We've talked about this a little bit. People have already addressed it. The tools that we have now, they're old. There hasn't been a lot of progress in research and development in half a century for drugs and almost a century for vaccines and diagnostics. I think we can all acknowledge there have been tremendous biomedical advances in the past half century, and unfortunately the TB community has not benefited from them. This has to change. So there's been a lot of progress in developing new and better tools to try to address this and to use these advances in biomedical technology and knowledge to really benefit the TB community. The goals for new tools are simple. We want simpler, faster, and more effective technologies. Simpler drug regimens that are shorter and easier to take. Faster diagnostics that will detect both MDR-TB and TB in people living with HIV. More effective vaccines that will protect across the lifespan. This slide, I won't go through everything on it, but what it's trying to show you is the innovations in new tools. What's happening now and what we're planning for over the next several years. And also to demonstrate that we can't have a breakthrough and then be complacent. That's how we got into the position we're in today. We developed a new drug and then nothing happened for 50 years. We developed a vaccine and then we used it for over 90 years. As we have breakthroughs, we have to use those as lessons learned and as information, and to keep building on those, to keep developing new and better and more effective technologies until we defeat this disease. You've already seen this, and I'm not going to go through these pipelines in detail, but what they're actually meant to show is how much progress has been made in the field. This is the pipeline for new drugs, what's happening in clinical development for developing new and better drugs, what's happening to develop new and better diagnostics, and vaccines. And I want you to just really appreciate how much is happening and the activity in the field and the progress that's been made, particularly towards later stage development of these new technologies. I want to spend a few minutes on new vaccines, and I want to show you this slide because I want to emphasize that we do have a vaccine. We've talked about it, but that vaccine is really targeted towards one population.